We go to the fine town of Utrecht in the Netherlands, and there we have Leonard Seelen and Dennis Klomp representing the Dutch High Field Imaging Hub, and coming in with the exciting title of a phospholipid imaging to prevent ineffective chemotherapy. So Dennis.
Thank you. Can you hear me?
Yes, perfect.
Thank you for introducing us. And I'm very pleased to be part of the Euro-BioImaging. Last Monday, we had our first introduction, and already on Thursday, we are allowed to present some of our work. So thank you very much. Just to explain a little bit who we are, I hope we can still stay in the Euro-BioImaging, because I've seen spatial resolutions up to micrometers and even below. And what we are going to show here is maybe only sub-millimeters or millimeters. So I hope you are still okay for us to stay in. Nonetheless, we are High Field Imaging Hub. We have a few imaging sites. We're scanning patients and subjects on 7 Tesla or 9.4 Tesla MRI systems, mostly for anatomy, so high detailed structural information, not only from the brain, also from other parts of the human body, let's say the heart or eye or extremities or even other parts. But in addition to that, since we have a high field, our noise goes down or our signal goes up. We may even be able to tune our system to other nuclei. So we would be able to scan, let's say, some part of the metabolism inside the human body. Here you see an example. So we do learn from your techniques. For instance, if we look at metabolomics, we see very good metabolites representative for aggressiveness of tumors, for instance, even up to 2 orders of magnitude of difference. And luckily, if we tune our systems to phosphorus, for instance, we are able to clearly pick up those signals from the human body. So that means we would be able to image metabolism in those subjects. And would that be relevant? Well, even clinically, that would be relevant if we would take a biopsy and we would look at the biopsy if the patient should get chemotherapy. If the biopsy says yes, we always do it. But if the biopsy says we don't know it, that's 75% of the cases, we actually don't know what to do. So, and then if we add our phosphorus scan, we see that with our 96% accuracy, if we look at the metabolite ratio, we see with that accuracy that the chemotherapy will not be effective. We still don't know if we're still uncertain. We could even go after the first chemotherapy and look at the response. And then we also see that if the tumor is not responding, we can clearly pick it out from the one that are partially responding. So we think that metabolic imaging through high field MRI could be of benefit. So how did we make this possible? Obviously, if you go for the brain, many of the high field systems are tuned for the brain, but as you know, most of the tumors, I think 96% are actually in the body, not in the brain. So we've tuned the system, 2 of those systems to other nuclei, so we can image the body. Now we can do this for other nuclei like phosphorus, deuterium, carbon, sodium, and a few more. But that requires high power amplifiers, so to get the signal inside the body. And if we do, you see a coronal view of the human body. You can see throughout the body, you can get metabolic information anywhere. That's basically the introduction for one of our users, Leonard Seelen. He's been in our group. He has passed his first year of PhD. He's going to present in a few seconds his work on the topic in cancer. And these are for one of the nodes. This is our node in Utrecht. The users that have helped us making all of this possible. So Leonard, maybe you can continue.
First of all, thanks to the Euro-BioImaging User Forum for this invitation to present over here. And I want also to thank my colleagues for their work and all the effort they already put into it. Dennis already told you I want to give you a presentation about phospholipid imaging to prevent ineffective chemotherapy in pancreatic cancer. And I'm a medical doctor and a PhD candidate from the HPV surgery and the radiology department of Dennis. The incidence of pancreatic cancer is increasing, whereas it's now 2,700 patients a year are diagnosed with pancreatic cancer in the Netherlands, with a 5-year survival of 9%, which is very low. It is the fourth cause of cancer-related death in the Netherlands, and a resection is the only possible curative treatment. But at presentation, 20% is resectable, 40% is locally advanced, also called LAPC, and 40% is metastasized. And the resectability of pancreatic cancer is based on the Dutch pancreatic cancer group criteria and based on 3 arteries. It's called an LAPC when it has more than 90 degrees contact with the superior mesenteric artery, the truncus coeliacus, or the common hepatic artery, or when it has more than 270 degrees contact with the superior mesenteric vein or portal vein, or when it's occluded. And as you can see the pancreas, and it has a lot of blood vessels around it. Patients with locally advanced pancreatic cancer will normally receive induction chemotherapy. And after 2 months, they will receive again a CT for restaging. But we see that 1/3 of those patients will have progressive disease, and in 2/3 of patients, they will have RECIST stable disease and will undergo an explorative laparotomy. But only 13%, in only 13% of the cases, it's possible to resect the tumor. And some people also underwent local ablative therapy like radiofrequency ablation. But almost all people will receive again chemotherapy. But the median overall survival of chemotherapy is nearly 14 months. And when patients receive chemotherapy and when a resection is possible, the median overall survival can go up to 32 months. So that's a big difference, but also very low. Here you can see CT images. In green, the tumor, blue, the vein, and red, the superior mesenteric artery. And as you can see, this patient is deemed irresectable. But what we did, we performed surgery on this patient and performed an echo. And as you can see, as the same tumor in green, that the tumor involvement is much less than we saw on CT. And that's all due to the fact that it's very difficult to differentiate between viable tumor and fibrosis due to the chemotherapy. Fibrosis we can resect, but a lot of tumor around the arteries or vessels, we can't just divest that tumor of the artery. So we need new kinds of imaging techniques, but also we need to assess how we can assess the best kind of tumor response on chemotherapy, because we already see some in 1/3 of the patients that they have progressive disease after 2 months of chemotherapy, and that's too long because those patients will have serious side effects. Thus, hopefully, we know a new kind of imaging to assess those people better, those patients better. And that's why we came up with phosphorus imaging. Phosphorus provides us unique information, including composition of cell membranes, detection of particular key metabolites. It gives us information about bioenergetics and oxidative phosphorylation. And it gives us the most important key metabolites are energy metabolism, the ATP, the phosphocreatine, and the inorganic phosphate. It also says something about membrane metabolism, and especially the phosphomonoester and phosphodiester, also called PME and PDEA. As you can see in the right down corner, you can see a nice spectrum we performed on a healthy liver. So our hypothesis was to hopefully that phosphorus MRI can reveal cell proliferation and energy metabolism in pancreatic cancer accurately enough to detect the metabolic alterations caused by the drug treatments. And that's why we set up the NIMI study. And the NIMI study is a study for non-ionizing metabolic imaging using robust phosphorus MRI to predict the treatment efficacy. Where all patients with an LAPC receiving FOLFIRINOX chemotherapy with a good WH performance score can participate. But we also wanted to scan healthy volunteers, because healthy volunteers will say something about how what's a normal spectrum and which key metabolites are normal in a healthy pancreas. Eventually, our primary objective is, of course, to determine the tumor response of a Phoenix chemotherapy in pancreatic cancer. But first, we need to do a literature search, because what's available at this moment about phosphorus imaging in the pancreas. But also, we want to see what will the reproducibility be of volunteers. And then, of course, we'll start our patient study. So we did. Here you can see, first of all, there were till now there's no available literature about phosphorus imaging in the pancreas, but there is in the liver. And we found 8 studies published something about the PMA energy ratio. So as you can see here, before there were 8 studies who were saying something about the ratio before therapy versus the healthy volunteers in that study. So you can see a lot of circles. The circles stands for a study. The bigger the circle, the more studies are involved in that study. But as you can see, you see that almost all studies found a percentile increase in the PME energy ratio before therapy compared to a healthy persons. And as you can see, after therapy versus before therapy, you can see a clear decrease in all studies for the PME energy ratio. So it looks very promising. What we also did, we scanned, we scanned a volunteer. So first of all, as you can see in the left row, on the left column, you can see the 7 Tesla MRI. We set to the MRI, did the liver in the second column, and in the third column, as you can see over here, it chose the best voxels with where the signal to noise ratio must be greater than 5. But we also did of course, the reproducibility, because what if there is a big difference from a scan of patient 1 compared to when we scanned that same patient a day later or an hour later? And so we did. And as you can see over here, we found, first of all, a lot of metabolites. In green stands for there was an excellent reliability between scan 1 and scan 2. Blue means a good reliability, and of course, orange, moderate reliability. So in conclusion, there were most metabolites showed a good to excellent reliability versus scan 2 versus scan 1. But we can also see that in the blend Altman plots. So as you can see, for all the metabolites, and especially in the last row, the phospho with the PMA and PDA, there were, of course, some variations, but not that big. So it looks very promising. And we also did the first MRS study for a 29-year-old patient with a pancreas tumor. And in the right upper corner, you can see the first spectra of a pancreatic tumor. So the next thing to do is scan more patients, scan them also after therapy, and compare those spectra when we quantify the metabolites with the healthy volunteers. So in conclusion, we showed you the first MRS results for a patient with pancreatic cancer, and we even detected more metabolites than there is available in the literature, whereas the reproducibility of the ratio of PDA and PMA, PDA over PMA in healthy liver is even better than 90%. So it's almost every time we scan a patient, the ratio will stay the same in that healthy volunteer. But of course, there are some confounders, like what will nutritional status and adverse effects of chemotherapy do on our spectra? And that's also what we're going to find out. I want to, on behalf of Dennis Klomp, I want to thank you for your attention. And if you have any questions, I can answer them.